enzyme, but tight LID. You see the pullback and the lumen profile on the right side of the screen. Little thrombus there, right next to the side branch. As Giovanni already demonstrate the console, you have this lumen segmentation in a matter of 3 to 4 seconds displayed to you. You see that Austrian diagonal there. And what I'm doing here is just defining my landing zones. So this is going to be my distal landing zone. And we are calculating how long is the stent going to be. I already saw that the diagonal is completely free of disease, so I'm not going to even bother protecting that branch. And we're going to just direct stent this. So in terms of usability, it makes the procedure pretty fast. And to Raj's point, probably really something I'm so glad that he mentioned with this wave of outpatient labs. If we can promote precision and embrace intravascular imaging, and really when it comes to the economics, you might offset some of the cost of the catheter by single wire, no pre-deal, and make the procedure very streamlined. Another quick example here, just to comment on the image quality on tight lesions. You see the non-STEMI on that RCA. See that there is a little bit of residual blood, but a very interpretable image still. It's almost 100 millimeters of vessel there, all the way to the guiding catheter. And you see how tight and presence of thrombus and plaque rupture and everything, and you still can image past that and define your distal landing zone for the stent. Another situation even more extreme, like a super tight circ. This kind of a vessel that you don't want to stent. So, but because it was non-STEMI, I felt obliged to image this again to try to roll out. I hope that's not my culprit vessel. And indeed, we are talking about lumen areas below 1 millimeter square, and you see that you still have good clearance on that super tiny vessel. No thrombus, that's not the culprit. Shift gears to the same patient here, to the LAD, long lesion. Can you see how the image flies on like when we trigger? And Raj, that's how ultimately you save that dye, because you don't need to keep injecting because it's flying at 100 millimeters per second. So this is that LID pullback. Superb image quality despite the very tight lesions. So the interpretation here is that this patient was having a type 2 MI because again there is no thrombus on the LAD either, and that's the result of the second layer of stent. That same case, post-stent, we did something a little bit unusual here. We repeat the pullback. I want you to compare the right side and the left side of the screen and make your judgment if there is difference on image quality there. I think they are essentially the same, with the exception that on the left side of the screen, the very end of the pullback, you start seeing blood coming. Okay, so what we did here, that on the left side was a pullback done with saline. So it's the same vessel with pure saline, and again capitalize on the very fast pullback 100 millimeters per second. and small catheter profile, it is doable to achieve quality image even with a non-contrast. Obviously, that the saline have severe limitations because of the lack of viscosity. You don't displace blood as well, so you need to inject at a higher flow rate and higher volume, and needs to be careful because patients can even VF if it's too much of saline at once. So I'm not promoting this to become a routine by any means, but I think we can start being a little bit more creative in diluting dye and really utilize a very, very small amount of dye per pullback. So this is the summary of HF OCT. The combination of a very fast laser that enable fast pullback coupled with a small catheter profile really make it the ultimate imaging for pre-intervention, because you can imaging the vessel without any need for pre-dilatation or vessel preparation, and achieve excellent image. This naturally for today's topic of ACS comes very handy, particularly in situations that you need to rule out which is the culprit vessel, and you don't want to pre-dilate in order to determine that. I stop here, Raj. Open for discussion, or I don't know if Evan was able to join already. Please let me know how you want to proceed.
Yeah, so we have several questions from the audience. First of all, I want to thank the audience who just joined here from US West Coast. I know it's very early on the West Coast, so thanks for being part of it. Also, we have delegates who has joined from India, Pakistan, Thailand, Indonesia, Vietnam, and China on our different platforms, and I welcome all of them. Really great to have you be part of C3 family and this show until we do the live C3 event. Dr. Oliver Krona, who is the course co-director of C3, has joined from Sweden. You know, Goran, I'm going to ask one question, and then I'm going to talk about a European experience for ACS. So one of the questions that has come from the audiences for Hiram is that Hiram, you mentioned a few times that no pre-dilatation is required. But what do you do in a case where a patient arrives with a STEMI and the vessel is 100% occluded? Do you do thrombectomy or PTCA before you do the image?
Yeah, so thank you, Raj. So that data that I present on the Octavia, the Italian data that we act as a core lab for them, the protocol was written in a way that you would need to have at least TIM 2 flow on the vessel in order to image. So that's how we still practice. So if often you can achieve this just by wiring the vessel, right, and restore at least TIM 2 flow. Or if you cross with the balloon, even not inflating the balloon. So, I mean, if on that particular studies, because we were looking specifically what's the substrate of the ACS, we were trying to be as minimalistic as possible, not manipulate the lesion, right? In the real world, I think I would prefer reestablish TIM 3 flow for obvious reason, and that's operator preference on how to do so. But as soon as you have TIM 3 flow, that will be followed by by the image. One thing that I would stress is that we talk a lot about the image, and unfortunately, I see a lot of my peers is still neglecting nitro. So if it doesn't matter how good is your image, if you are not generous on nitro, you are missing the point, right? Because on ACS there is always a fair amount of vessel tonus and spasm. So when you start measuring what you need to measure, you are completely off. I mean, your measurement is correct, but if your image without nitro, you come up with wrong conclusions.
So we have a couple other questions. Dr. Rob from Emory University, who's just recently built a brand new lab in a new hospital. He's also our course co-director of the C3 course, has joined us from Atlanta. His question is this new technology can be integrated with a current cath lab cameras? And Giovanni can take this, or Hiram can take this, and I'm not familiar with the technology as well to answer this.
Yeah, no, it's a very good question. So yeah, the console is designed that you can connect it to the angiography system. So in the OCT console itself, you can display the OCT data next to the angio data, and the two data are synchronized in time. So when you play the OCT pullback, you can follow the X-ray marker on angiography moving together with your images.
That's that I think was, you addressed co-registration. I think that what Dr. Rob's getting at is that I have in my lab a 16 screen, where multiple images can get on the cath lab screen without having to roll around with a mobile unit. Is there a connection directly into the cath lab screen so that we can operate remotely from the table without somebody has to be scrubbed or have a second person dealing from a console to
Yes.
measurements, etc.
No, it's okay. I understand the question. Yeah, so today we only offer a console that you can move around. The console has the ability to be connected to the cath lab screen. So if you prefer to look to the OCT images on the big screen in front of you, we have the ability to do so. But we don't offer today a fully integrated system. So it's always a console that will need to be rolled around and moved to the different cath lab rooms.
Yeah. So that's the answer that he was looking for. Dr. Halapas have joined from Greece. Thanks all the Greek colleagues. I did not miss them. Dimitri is always our staple in C3 Congress. So thank you everybody at Greece to be part of it. Let's continue with a couple more questions. Question came from India about that you did not address plaque erosion. So there's a lot of young patients that come in Indian continent with an acute STEMI, and after thrombectomy, the vessel looks fairly clean. And if they suspect that this is plaque erosion, and obviously OCT would be a great device to diagnose plaque erosion. So Hiram, you want to address plaque erosion and what do you do with it?
Sure. As you said, Raj, I mean, I think that there is emerging data that some of these cases we can defer PCI. I think this is still early days. That's probably the biggest controversy that we can talk about. I want to just remind all that the evidence of PCI in the setting of ACS versus conservative is overwhelming favor PCI, and we're talking about hundreds of thousands patients, not a small series of patients. So I would just be very cautious on how to embrace the new concept, but there is definitely a small series of patients that follow, and patients do well if there is no residual hemodynamically significant stenosis, and specifically the concept of sub-selecting the ACS population between plaque erosion versus plaque rupture. It is somehow appealing, but also there is no clear evidence that you could not do the same even with the plaque rupture, right? Because if it boils down to, do you have hemodynamically significant lesion, yes or no? Well, that might apply for both plaque rupture as well as plaque erosion. So this is just a word of caution. The other word of caution is that, as I present on that Octavia data, is that even with the best image in terms of identifying substrate, namely OCT, there is 25% of the case that the like a core lab, 2 observers, very trained people are unable to rule out plaque rupture, right? Why? Because when you have superimposed thrombus, you have attenuation of the light, and you can't really tell if there is no plaque rupture underlying that thrombus, right? So the concept is out there, but I think we need to continue to collect data in properly done prospective fashion with follow-up and really look at patient outcomes. It is empowering when you have the image. There is no plaque rupture. There is just a little bit of residual thrombus there. You have a big lumen. Yeah, this patient is probably going to do well, and you might want to defer that case. But again, let's just be cautious, because we are talking about decades of data that are being accumulated favor PCI over conservative, and in my personal practice, if it matters for the discussion, I'm not routinely deferring PCI on ACS. If I identify the culprit in principle, that patient is going to get the stent.
Gotcha. Okay, well, that's great. So now Dr. Schlafmitz from New York has been able to join us. He's actually in Dallas, but he has made a special accommodation to be part of this session. He's a rising star. His dad and I've been colleagues for a very, very long time. And Dr. Schlafmitz and I worked on imaging from its inception. We were one of the first ones many, many years ago who embraced OCT. And Evan is now doing a great work as the director of intravascular imaging at St. Francis Hospital, and really is making a name for himself. He did his interventional fellowship at Georgetown and MedStar Washington Hospital Center, and also had done an intravascular imaging and physiology fellowship at Cardiovascular Research Foundation and Columbia with CRF group, and now is working at Heart Center and St. Francis in Long Island. So without further ado, I'll turn over to Evan, who's going to address IVUS versus OCT in ACS and continue with this session.
Thanks so much. Thank you for the invitation and the kind introduction. So yeah, we'll be talking about intravascular imaging in ACS. These are my disclosures. So intravascular imaging of plaque rupture, you know, it was a great conversation you were having before. And these entities, whether you're talking about plaque rupture, plaque erosion, you can't determine this based on an angiogram. The only way you can figure out what the root cause and the lesion morphology is with intravascular imaging. So here, if you see on the left, we see an OCT cross-section where you see a ruptured plaque. And what that arrow is pointing at, you can actually see that entry site where the plaque rupture occurred because of that high resolution and sensitivity with optical coherence tomography. You also see with the asterisk some thrombus that's coming from within the lesion. And the exact same lesion, the cross-section we have in the panel in the middle, panel B, which is a high definition intravascular ultrasound. And here you notice, while you can still make this out, it becomes a little bit more difficult to tell. You can still see where that entry site is if you look closely, but if you didn't have that OCT image there, and you were just assessing this in real time in a patient with a pullback, you may miss that because it's not quite as obvious as you can see with that clearly demarcation on the OCT. Now, the exact same area, same patient, same lesion with 20 megahertz IVUS on the right. So here you see it's essentially unable to be recognized, that same affinity, or you wouldn't be able to see that entry site, the plaque rupture, and the thrombus. However, everything in life is a trade-off, and there are some advantages with the 20 megahertz IVUS. You can see because of greater depth penetration, here you can see the entire vessel, the EEL, and the media, the dark black circle encapsulating that vessel. And that's what's missed on the OCT and the high definition IVUS on the leftward two panels. So everything is a trade-off anytime we're choosing intravascular imaging devices. But I think over the next couple of minutes, you'll see with ACS particularly, where we're really wanting to look at the luminal surface, there are a number of advantages with OCT. And you'll see why that's my predominant modality for ACS. So here's an example of a patient who presented with a STEMI involving the LAD. And we see the filling defect on the angiogram inset on the left labeled D. And right next to that, there's co-registration demonstrating where each of these OCT cross-sections are coming from on that angiogram. And you can see with this frame-by-frame analysis how critical intravascular imaging is, not just in guiding our PCI as with every procedure, but really in figuring out exactly what the culprit is, where the culprit is. And once you know that mechanism, you can fine-tune both the PCI treatment appropriately, but it also helps you target pharmacotherapy after the PCI as well, because you know exactly what the lesion morphology is, and it helps you guide optimal treatment. So here with the OCT is obviously done after aspiration thrombectomy and once flow has been restored so you could get a high-quality image. You see a lipidic plaque with thin cap fibroatheroma, and you're able to identify the thrombus, and you're also able to identify the site of rupture. So in the lower right-hand corner in panel F, here you can actually see that cavity and that plaque rupture. So this, because of that high resolution of OCT, this is something that can clearly be assessed. This is a completely different patient, but again, you're able to see, you're seeing this repeatedly. Panel C, this is another patient who presented with STEMI, and you can see that plaque rupture. So you're seeing that cavity where that rupture took place. I'm just showing the multiple examples to show how reproducible this is in real time. Once you've restored flow, if you do baseline OCT prior to stenting, you're really able to identify the culprit and assess what the cause of that patient's presentation was. Now here's a slightly different type of appearance. This is the plaque erosion that you guys were just discussing. So this is a patient also presented with STEMI. And you see with the OCT, you can see similar findings. You see the culprit lesion. You can see the thrombus with the arrowheads pointing at what's mostly white thrombus. On OCT, white thrombus is going to be better demarcated, whereas red thrombus is not able to be demarcated. But even though you're able to see the thrombus, if you see the intima is all intact, there's no disruption in the intima, regardless which panel you're looking at. As we go proximal in the panel A in the upper left, to distal all the way in the upper right, the intima is intact throughout. There's no plaque rupture. And as a result, this lesion tends to be plaque erosion. I agree with Haram. Most of these, although there are some small studies that show that it is safe to manage with pharmacotherapy as well, most of these lesions I end up treating with post-PCI, particularly if there's a stenotic segment with significant residual disease. So here we see there's still lipidic plaque, and we've proven that this is a high-risk plaque. The patient presented with acute MI. So that's why in the absence of larger scale randomized controlled data, most of these I am still treating with PCI. And here's another example of a patient presenting with ACS. It's a relatively young female presented with ACS. And you see here the OCT is demonstrating a completely different entity. So here we see a nice example of SCAD. So in C, in the panel C, we're able to see that arrow showing exactly where that entry point is and where you see that dissection. And what's different with SCAD, what you're seeing here, if you look at panel B and E, the proximal and distal references, you see it's a relatively normal vessel. These vessels are free of disease. SCAD typically occurs in otherwise healthy and normal vessels without plaque. What's important though with OCT, even though you don't get the depth penetration and you can't see the vessel necessarily, in the presence of large hematoma, you can appreciate in panel D how significant that intramural hematoma is. There's an asterisk there showing where that compression is occurring on the lumen. So SCAD very easily recognized that OCT. It's helpful when there is some ambiguity based on the angiogram. I will just caution when you recognize these patients, if you can recognize this based on the clinical presentation and the angiogram, this is one of the few times where I often avoid intravascular imaging. If you're not going to be treating it with PCI, there's obviously advantages of not having to wire the vessel. And one thing just to note with OCT, in order to clear the lumen from blood, we do have to inject contrast. And with SCAD, there's the theoretical concern that can propagate the dissection. So while it does make for excellent images, this is another example where IVUS may have an advantage. So most of these ACS scenarios, OCT is my preferred modality. You can certainly see with higher resolution with OCT, but IVUS does have an advantage that you don't need to do any high pressure injection to be able to obtain your image. I'm going to move on to another case example, and this is what I call as stentless PCI. So here is a young patient presented with stemming. Aspiration thrombectomy was performed. Once flow was restored, did baseline OCT. And what was remarkable here, it was a completely normal vessel. This is different than plaque erosion, where it was a segment with plaque. The entire vessel was completely free of disease. So here, this was a case where I felt very comfortable not performing stenting. The PCI was just a removal of thrombus, but it was clear this was embolic. There was no plaque that thrombus derived from, and I was comfortable not implanting a stent. And had it not been for the imaging, the reflex would have been, once I restored flow, the next thing would have been to balloon it and stent it. But as soon as thrombus was aspirated, there was no residual lesion. And fortunately, by doing OCT, it completely changed the course of this patient's natural history. Because without a stent, this was a young patient in their 30s. They didn't need to be on dual antiplatelet therapy, and instead was putting them on an oral anticoagulation and was able to save them having a stent in an otherwise healthy artery. Again, that's something you wouldn't know without intravascular imaging. So now just going back to the comparison, here's another example with HD IVUS comparing with OCT. You can really see while there are on the top line is the IVUS, and you can see with the yellow arrowheads where there are some defects that an astute clinician can recognize that as thrombus. But I think when you're not looking at this on a computer screen in PowerPoint, a couple of inches from the screen, in a lot of labs, the IVUS screen is set up, several feet away. And it's very easy to miss. So I think that's really why OCT has a number of advantages, particularly with ACS. You can see the corresponding OCT image in panel B, panel C with the yellow arrowheads, how easy you see this intraluminal protrusion. It's very clearly demarcated. You know that's thrombus. It's a lot easier to recognize. And the whole purpose we're doing intravascular imaging is to guide our procedure, get better outcomes. And the easier it is to recognize this, the more likely you're going to be able to make an appropriate diagnosis and act on that. So just quickly, one final case. This is a patient who presented with an NSTEMI. Here we see, looks like a focal lesion on angiography. When you do OCT here, that same lesion, what we see is plaque rupture with substantial amounts of thrombus. You see the rupture site. And here's just the still frame of the culprit lesion. You could see the amount of that thrombus with the asterisks. Patient was treated after administration of Cangalore, went in with direct stenting. Again, the baseline imaging is critical with ACS because you can tell your plaque morphology and whether you can do a direct stenting approach, which I often find is best in thrombotic lesions, help to prevent residual no reflow and distal embolization. So if you see it's not a heavily calcified vessel, which you could really only appreciate on the intravascular imaging, a direct stenting approach is often ideal after post-dilatation. And then you've already purchased your imaging catheter. Anytime you use it pre-stent, you also want to use it post-stent. And here you can appreciate that you've had PCI optimization with significant reduction in residual thrombus post-PCI. So here you can just see the side-by-side comparison with substantial thrombus at baseline and post-stenting, an optimal outcome. Now, just one final point I want to drive home. So we looked at a series, because intravascular imaging standard in our cath lab, it's really used universally for all procedures. We assessed patients who came in with a reliable story, an ACS presentation or stable coronary disease, but with typical chest pain. Yet they had non-obstructive disease on an angiogram. So for these patients, we did serial intravascular imaging to assess, was there actually a culprit for their clinical presentation? And what really was eye-opening was a quarter of these patients had a significant culprit by intravascular imaging, which was completely missed on an angiogram. These are the cases where if we weren't doing imaging, we tell them, oh, you know what, it's reflux, take a PPI, where, maybe it's musculoskeletal. And we completely would have missed the diagnosis. And if you see here, 25% of patients had a significant high-risk finding, things such as plaque rupture, a calcified nodule with overlying thrombus. So you don't know if you don't look. And that's really why I strongly advocate for routine intravascular imaging. You're going to get a more accurate diagnosis. And aside from that, when you're treating with PCI, you can get an improved outcome. So for intravascular imaging for ACS, I think it's critical to identify what the etiology of the patient's presentation. Then as a result, you can tailor therapy. That's the true essence of precision PCI. It's tailoring therapy to that patient based on the morphology of that lesion. And then you're also going to be using the intravascular imaging for procedural optimization, choosing the right stent diameter and length, making sure there's no further optimization needed at the end of the procedure. Which device to use, you always want to select the best modality for that individualized patient. In my practice, the majority of time in ACS, OCT is my go-to imaging modality. I think the cases where IVUS does have a role in ACS, for me at least, it's SCAT if I need to do intravascular imaging, and particularly with osteal lesions, if it's an osteal RCA or left main, because of the difficulty in clearing blood and getting an optimal image with OCT, I'll often use IVUS, as well as for large aneurysmal vessels, I'll use IVUS. But in the remainder of the cases, OCT, for the reasons you saw during this talk, is my go-to imaging modality. So I'm happy to have any further discussion, answer any questions you may have. Thanks so much.
Thank you so much, Evan. We're almost out of time, but there's a couple of questions from the audience, so we'll take those. and then we'll conclude. Is there enough data to demonstrate safety of OCT in SCAD, and whether the new technology of the new high frequency OCT, where you don't have to inject large amount of contrast, provide better safety in SCAD cases?
Yeah, that's a terrific question, and yeah, so with the newest OCT, not only it's a smaller catheter, but it's a more rapid pullback. So because of the rapid pullback, you're injecting much less contrast. So first of all, it may be safer to do that. But even with the pre-existing OCT, this is all theoretical. I've seen no data to show that injection of contrast with OCT leads to propagation of the dissection. And I think it's a really important point. I personally believe it is a myth, because if you think about it, you're injecting for an angiogram. If you're injecting contrast with an angiogram and that's not propagating the dissection, it's the same PSI. If you're using a power injector with assist, you're using the same PSI when you're doing your OCT pullback that you're using for your final angiogram, which most people are going to take a final angiogram, even if they've seen SCAD, they may take a second view after. So if, is it possible it's propagating? I'm sure it is, but I haven't seen any robust data to demonstrate that there is significantly increased risk with OCT for this entity. I agree with your comments. High definition OCT may be better. And I think really the real risk comes to wiring the vessel more so than the imaging catheter. It's probably the wire where there's the risk of propagating that dissection more so than that injection, because when you're doing a hand injection, it's not much different than when I'm injecting just to obtain an angiogram anyway.
I can't agree more. I really think that the risk is really in the wire rather than once you have the wire down, I don't think there is a problem. Here's the last question that came is for Dr. Ugi, is is there any bench data on OCT with a CO2 injection for, say, dialysis patient or a renal failure patient? Has that ever been attempted?
So I'm not aware of that with CO2. There's been a lot of interest in alternative agents to contrast. So the whole purpose is you need to clear the lumen of blood so that with OCT you can obtain an adequate image. As long as you're clearing the lumen of blood, you can obtain that image. It doesn't have to be with contrast. There's been some work with dextran as an alternative. One of my partners is Ziad Ali, so most of our understanding in our lab comes from his work, and the nephrologists we work with want us to avoid dextran because that could potentially be nephrotoxic. So while that does provide for high quality images, we don't use that in patients with CKD. What we are using, I haven't tried CO2, I haven't seen any data on that personally. We are using saline. Saline provides excellent image quality. Outside the US, it can be used. It's on label outside the US. In the US, it's just cautioned it's off label, at least with the Abbott OCT system. But it's something that we've done significant research on. It's safe. It provides for accurate vessel assessment and high quality images. The one caveat with saline, it dissipates quicker than contrast. So as a result, you get a shorter pullback that's necessarily analyzable. And that's what I think will be interesting with newer OCT modalities, to see with a quicker pullback, can you obtain long, high quality OCT images with saline? Maybe Haram could comment on that. He probably has the largest body of experience with this high definition OCT.
Yeah, I know we're running out of time here, Raj, but just a comment on this contrast utilization, I think is an important one. I always agree with Evan's comment that we probably need to rethink the focus here, rather being things that are already in Alpo, like saline, and not keep chasing new agents because ultimately dextran, it is a drug, right? And logistics are not that simple. There is description of allergy to dextran, et cetera, et cetera. So I think what is readily available for all of us is obviously saline and contrast. And so diluted contrast, I think, is a good compromise at this time. But probably even more important is how you plan your procedure, right? I mean, when someone come with low GFR in a provocative way, I say, oh, we really should do this case with OCT. So I just have people raising their eyebrow. So well, if you keep doing what you do and you add OCT, it's a simple math, right? You're going to spend more dye. But what OCT enables you is to be minimalistic on your angio projections, right? So you only need one projection, and I would not compromise my pullback quality, even if I need to go full dye. And then I have a perfect image of that vessel. I'm not doing puffs. I'm not doing 3-4 projections to define my lesion. I have my game plan there. And then we are really minimalistic on the grand total of dye, just because you are planning things in a better way, right? So I think that's the main opportunity to save dye, is to be minimalistic on your angio, right? And prioritize not compromise the OCT pullback. Yeah, the best pullback you can. Yes, the HF OCT is gonna help a little bit with that. Just by the fast pullback, you can save about 5 cc's every time you do a pullback. But the grand total, as we know, it has a lot to do of test, and stop testing, stop and take a bunch of projection, right? And at the end, you're gonna end up, even in complex case, with a minimum amount of dye.
It's such an important point, Haram, because if you can take high quality image from within inside the vessel, you don't need multiple angiographic projections. And if you know you're going in with OCT, it changes your diagnostic angiogram. So you use less contrast there. Post PCI, you don't need 2 orthogonal images. If you have an optimal result on your final OCT, that's my final picture. And I'm efficient with my contrast. Even though I use contrast for that OCT, I end up using less contrast than if I wasn't using intravascular imaging. And as long as you pull your wire back slightly on that final image, you're getting a free cine out of it. You make sure on that final OCT pullback this way, you don't have a distal wire perf, and everything else you get from the OCT. So I agree completely with you.
Goran, any final comments?
Thank you very much. Great to see you again, Raj, and great lectures, guys. Really appreciate it. I'm not so familiar with a high definition OCT. Is it a CE mark yet available in Europe?
Giovanni?
Yeah, thank you for asking. So as of today, it is commercialized in Japan and in the US. We expect it to be available in Europe very soon, but today we don't have a clearance yet. But it could be as early as Q1 2023, so starting next year.
Great. Dimitri, any comments, concerns?
Yeah, I'm very happy to see you all, first of all, and I'm very happy to see that coronary intervention are still evolving. This is really good. I mean, because we're running into the era of structural heart disease. But I'm really happy to see that there are many things involving in coronary interventions as well. So as regards the high FOCT, I think it's a great advantage. I mean, saving the contrast, having this long pullback, 100 millimeters with one shot only. I think there are really great advantages that you can do OCT all the time. And since we do continuously more and more routinely now, more and more complex procedure, I think intravascular imaging is getting more and more important. And don't forget that all the data have already proven that intravascular imaging improves the quality of our procedures and the outcome of our patient. And one final comment regarding the contrast that we're using in OCT. I heard previously that diluted contrast with saline was suggested. I think that we have to be careful about this because due to different viscosity, the contrast in the saline cannot be diluted easily. As you know, probably a couple of years ago, we have been pioneers with my mentor, Bernard Lamis, to do OCT in carotid procedures. And then we were trying to do dilution of the contrast with saline to do less contrast injection to the brain in order to see and have a good imaging with OCT in the carotids. However, we found out actually that this is not possible to be done. You cannot dilute saline with contrast. You need different pumps that they can inject the saline and the contrast in a different way in order to have diluted. So it's not easy to do. You cannot easily do with a single pump. You cannot easily do with a hand injection. So I think contrast it's enough. I think 6 millimeters of contrast, or even 5 millimeters of contrast cannot harm the patient. As previously said, you can spare some contrast from the coronary angiography itself. So it's great advantage.
Well, these are all great points. Thank you, Dimitri. Thanks, Hiram. Thanks, Dr. Ugi, and thanks, Evan. Great session. We look forward to having all of you again on December 10th for our next Coffee Cases and Controversies. We're going to announce what that session is going to be about next week. It's going to be about a very, very interesting new topic. Precision PCI series is going to continue in January. A lot more announcements to come regarding C3 in the next few weeks. So look forward to having you all again live in the C3 Congress sometime in the next summer. That's going to be very exciting news. And with that, I'd like to conclude today's session. Genuity should be very happy that we're generating a lot of interest for them for the new device even before the device is fully launched in Europe. So I think it's very exciting technology. We look forward to learning more about it. And everyone have a great rest of the weekend. Thanks again, everyone from across the world that's on this session today. I know some of the places that are very late in the night. So thanks, everybody. Have a great evening. People in Europe, have a great rest of the afternoon. And look forward to seeing you soon.
Thank you. Thank you so much.
Thanks.
Thank you, guys. Enjoy Saturday. Bye.
Thank you. Thank you very much.